Okay. You still see the screen, right?
Yes.
Okay. Bismillah. So the first concept we will talk about is the incidence and the prevalence. Right? So you know that like in Biostat, even if you are preparing for step 3, you need to know these, simple concepts. When you know it, like the difference between step 1 and 2 and 3, like for me, like I noticed that step 2 CK questions are harder than step 3. Step 3, maybe the drug ad are harder, but in general, when I did the 2CK, I felt like the way they're asking the simple concepts, it's more complicated, like very simple concepts, like for example, the case control studies, the cohort, the retrospective studies. It will take you time to understand which one is the exposure, which one is the disease, when you are looking in the patient's medical records. Did they start having, the exposure and then following up to see the disease outcome, or it's the opposite? So in general, the formatting or the wording of the questions in step 2CK, it's hard. It's harder than step 3 and step one as well. So that's why, like, there are very simple things that you think that you are understanding, but when it comes to the question, you might find difficulty to apply this, simple concepts on the questions to solve the questions, including like incidence, prevalence, as I just told you, the case control study, all these, simple stuff. So that's why whenever you come across anything, any concept, whether it's easy or not, basic or not, just try to ask yourself, what is the definition of this thing that you are studying? For example, now I'm like talking to you like about the incidence, right? So what is the definition of this? And excuse my beautiful writing, because I'm still practicing this, writing on the board. So the incidence and the prevalence. What is the incidence? What is the definition? Always ask yourself, because when you ask yourself what is the definition, you will be able to solve the question if it becomes in a difficult, wording. So incidence, it is the cases that are new. It is new cases, okay? And these new cases over a period of time. So if I'm telling you, like, I want to know the new cases of the COVID-19, I can tell you in 2019 or in 2012, in 2020, or which time period I want these new cases, okay? So, and it is over what? It is over the population at risk. So it's not over the whole population. So if I give you a population that is 1 million population, and I give you the number of new cases, let me admit, and I give you a number of new cases for a certain disease, and I told you what is the incidence of new cases, you will take these new cases, but you will not put the denominator as the population at risk. The denominator, sorry, not the 1 million, it will be the population at risk, which means, for example, the population who were exposed, for example, to other people who had the infection, or in HIV cases, if the population at risk will be the IV drug user. In epidemics, not epidemics, in outbreaks, the population at risk, for example, if you're having gastroenteritis, you're not going to take the whole population to know how many cases happened for the gastroenteritis. You will just talk about you will take the new cases of gastroenteritis over those who ate in that restaurant, for example. So this is the population at risk, and it is only the new cases over that period of time. While in the prevalence, you are like, it's like this. You are taking this period of time. You will see who is sick during this period of time. During this period of time, it will include new cases and also the cases that was before. Like if the patient get the sickness here, and when you check the prevalence during this period of time, he is still sick, right? So you will include him in your equation over the population of your interest. So, so now when you understand the definition of the incidence and the prevalence, if you get like a question whether like, and I always like to tell myself and also to tell you, when you study, yes, you are studying for the exam, but all these, you know, things, it will help you for the exam, and it will also help you as a physician when you read papers. So if we had like in the subject review, we have a question about the incidence of hepatitis C. If I give you like hepatitis C virus, okay? And I told you, and I told you like, I want to know the incidence of hepatitis C virus in the year of 2000, okay? And you can see like a long question, there is too many like numbers in the question. So if you don't know what is the definition, what is the equation of the incidence, you will be confused which number I should take, right? But if you know the definition, it will be easy for you that to eliminate all these numbers that are in the question and just pick the one that you know that this is related to the equation or to the definition. So for hepatitis C, if I told you I want hepatitis C in year of 2000, and I tell you that the population in the question, I told you the population is 10,000 people. This is the population. And I told you like when I started the study, there were already 200 cases of hepatitis C. And then I also, to confuse you, I told you that there is also 200 new cases of hepatitis B virus, just to confuse you, to know that when you read, you know that what you are looking for. And I told you out of these 200 cases, we had like 50 who recovered, and we have also 50 who died, okay? 50 who died. And then I told you in this population, um, let's say, 1,000 people who are IV drug user. And I asked you what is the incidence of the hepatitis C virus. So from all these numbers, which numbers are you gonna take? You're gonna take simply the new, did I give the new cases? I didn't give you. So, and I told you during your study, there were like 2,200 new cases. Okay, and the study, it was between 2000 and 2002, okay? For 2 years. It is a 2 years study. So I did my study for 2 years, and these are all the numbers. And during this 2 years period, I got 200 new cases. And when I started the study, there were already 200 cases before. And then I told you what is the incidence of the hepatitis C. When you see this, you need to know what type of incidence I am asking you. Is it a general incidence? Like I'm just saying, what is the incidence? Am I asking you for weekly incidence? Is it monthly incidence? Is it during the whole period of my study? Like if I was doing my study for 5 years, am I asking you the incidence during these 5 years, or it is during 3 years, or the annual? So you have to know what am I asking for, okay? So if I'm asking about the annual in this example, you will ignore all the numbers. You don't need the cases that was already, like when I started the study, if I already have 200, I don't want these because I'm not looking for the prevalence. I want during my period, how many people get the disease, the new cases. So I will take the 200, which is the incidence. This is the incidence of the new cases. And then the denominator, is it going to be the 10,000 population? No, this is the general population. It will be the population at risk. Who are the population at risk? They are the 1,000. So this is the population at risk. But from the population at risk, there were already 200 people who were having the disease. So you will minus this, prevalence from the denominator. So you will do 1,000 minus this 200. So the denominator, it will be 800. So always make sure that you are minusing from the denominator, which is the population at risk. You will be minusing those who already have the disease, because you don't want them in your equation. You want only the new cases. This is number 2. Okay, now this is my incidence, but this is my incidence during the whole time period. It's during the 2 years. What I asked you for annual, right? So just by default, like when you have 5-year or 2-year period, if I'm asking about the annual, it will be half of this, right? 200 divided by 1. So it will be 100 divided by 100 new cases divided by the 800. So this will be my the incidence. So as you notice, you take in the numerator, it will be only the new cases during the period that you are looking for, okay, or that you did your study. But during this period, make sure, is this period 2 years, 5 years, how many years, and what I'm asking for. If I'm asking for annual, you will divide that period by it. Like in this example, the new cases, it was 200. And then I'm asking about the annual risk, which means it's going to be 100 only. From the denominator, you will not take the whole population, you will take only the population at risk. And then from the population at risk, you will minus those who already have the disease. For those who recovered or who died, these don't even look at them. You don't need them in your equation um, when you are talking about the incidence. So this is when it is about the incidence. When you're talking about the prevalence during this period, it will be those who already have the disease, which is 200, plus those who are new cases. So it will be 400. And then from the prevalence, from the denominator, you will minus those who died from the disease and also those who recover, because you don't want them, because they're not existing. Like if this is the period of the disease, like, and you have the disease here, if you died or recovered, so you're not anymore in this period, you already died or recovered, so you will minus them from the denominator. So this is when it comes to the idea of just doing the calculations, or knowing just the general definition of incidence. The other thing is, if, like, for example, the simple question that they might ask about the incidence and the prevalence, like if you are improving the quality, whenever you are improving the quality of care, you have quality and you have vaccine. So when you are improving a quality of care, like if you're having diabetes mellitus, no, I want something, yes, diabetes mellitus, like long time ago, when there was, especially type 1, when there was no insulin. So anyone who's having diabetes mellitus, he would die, right? He would die. So when you do the prevalence, during this period, these are already dead, right? So it will not be included in your equation. But now, because we have insulin and we have better quality of life, now when you're doing the prevalence, it will be increased. With improving the quality of care, the prevalence always increase, because you're making these people live longer. They're not dying and they're not also recovering, right? So like there is no cure. I'm not talking about a cure. I'm talking about like improving the quality of life, especially in these chronic diseases that you cannot cure. So improving their quality means that they're gonna live longer. And when you check the prevalence, will be increased. Does the incidence get affected by improving the quality of life? Of course not. There is no incidence. Like the new cases of diabetes mellitus, it will be the same, but they will live longer. Well, what about vaccine? Vaccine, you are preventing the disease from its happening from the beginning, so the disease will not happen. So when you prevent the disease from happening, you will decrease the incidence. The incidence of the disease will be increased, and also the prevalence will be also decrease. Both of them will be decreased, not increase here. It will be decreased. When you're improving, the incidence will be decreased and the prevalence will be decreased when you are giving vaccination. So this is number one, improving quality of life we talked about, and immunotherapy combined, the quality of life. What else here in terms of the incidence? Okay, we talked about the equation. Same thing, we talked about the vaccination, that you're gonna improve the quality of life. Okay, and then you have some equations that you need to understand, like this. Like if I asked you about the mortality, I want the maternal mortality, okay? Maternal, so it makes sense. You don't need to memorize it and all these things. What is the maternal mortality? You want to know how many live births that happen, like you have 1,000, for example, 1,000 live birth happened during that year. And then over this live birth, how many mom died? So the death among these mothers. So it will be just the maternal mortality. It will be the number of the mortality of the maternal death by the number of the live births. So out of these live births, like if you have 1,000 or 100 or whatever, how many mom died during these live births? So this is the maternal mortality. Crude, whenever you hear the word crude usually it means like it is like when you translate it crude, it equals like unstratified. Okay, so it means like for me, like I understand it like it's a general thing. You don't specify it. So whenever you hear the word crude, usually the denominator it will be population, the population, all the population, not the population at risk. Okay, the population it will be whenever you see the word crude. That's what I noticed. Like crude, usually you take the whole population. So if I'm asking you about the crude mortality, it will be the mortality or the number of those who died during that year over the total population. It's not related to the population at risk or the population who died from a certain disease. What else we have? Crude, another crude word, we have also crude birth rate. So here crude mortality, and here we have crude birth rate. Same things, it's crude, so it will be, the denominator will be the whole population. It's not like population at risk or specific population, it will be the whole population. And you will have the number of the live birth. Okay, so how many in this population, how many live birth you are having. So usually crude, you will have just the population in general. And I'm saying that because we have another type of mortality. You have cause mortality, and you have the cause specific mortality, cause specific mortality and case fatality. So cause and case, okay? So this is cause and this is case. So it seems like this is more specific, right? So it's about the case. So if we are having diabetes mellitus, and we want to know the cause versus the case. In the diabetes mellitus, for the cause, you will take those who died from diabetes mellitus, right? That's why we call it cause. Why cause? Because you will take only those who died from diabetes mellitus, not from heart failure or any other cause. From this cause you want, and then you will divide it by the population in general. But when it is case fatality, you will take those who died from the diabetes mellitus, and then you will divide it by those who has that diabetes mellitus. So it is the case, it's about the case fatality rate. So it will be the denominator, it will be the cases of the diabetes mellitus. If you're having 100 cases, how many out of this 100 died? For example, 5. So 5 out of 10. While here, if you're having from the total population, if it is like 1 million, how many died? For example, it's 100. And that's the difference between the three mortality or fatality equations we have. And what else we have? We are left with two definitions also. One of them is you have the attack. Whenever you hear the attack rate, this is usually, it is related to the usually case control studies. It's related, like always correlated with the case control, and always correlated with the I don't know, I always forget this word, outbreaks. Okay, so if you were invited in a restaurant and then you came back from the restaurant and you're having diarrhea, any outbreak, you're having diarrhea, what am I going to calculate? If I asked you, what am I going to calculate? I'm going to calculate the attack rate. What type of study, what study design I'm going to use? I'm going to use case control. Why? Because I'm going to go to everyone who went to that restaurant. I will ask, do you have diarrhea? And or do you some of them, they will say yes, some of them they will say no. So these will be my cases, and these will be my controls. And then I will see from my cases, from those who develop diarrhea, I will ask them, what type of food did you eat? Some of them will say rice, some of them will say potatoes, some of them will say like soup. Same thing here. Some of them would say rice, potato, and soup. And then I will see how many cases. I will measure the attack rate. We call it the attack rate, which is the number of cases divided by those at risk. So I will see how many develop the diarrhea in the rice, how many develop the diarrhea over the number who ate the rice. Same thing, how many develop diarrhea here over those who ate meat, how many develop diarrhea over those who ate the chicken or whatever, or the soup, same thing. And then I will see the highest attack rate. These will be, for example, if the highest attack rate was among those who drink the soap, so I will say then it seems that the diarrhea was due to the soap. If it was like in multiple of them, I can like add all these attack rate among them all over their total number. So how many people ate rice? Let's say 10 here, 10 here, 10 here, so it will be 3. And then how many developed diarrhea here and here and here, and then I will add it, and this will be the attack rate. So the definition of the attack rate, it will be the incidence, which is the number of patients with the disease, by the total population at risk. It has to be at risk. Okay, it's not like the total population in general. It's at risk, which means who ate these certain type of foods in that specific restaurant. Any question here? Okay, let me yeah, when I ask you if you have any questions, if you don't have, just let me know, because I want to I feel like I'm alone when you don't.
No, we are
Yeah,
fine.
no question.
Thank
We're
you.
good. Thank you, Ada.
Okay, welcome. Okay, who's this? Fatima? Who's Fatima? Can anyone, you guys, help start to enter the Zoom meeting?
I'm trying.
I already messaged them. That you just have to download the Zoom on computers, and then you can come in without
Open
any
the
password, I
account.
think.
Yeah, I'm suggesting them to download it and open the account.
Yeah.
Is Star with us? Is she with us or no? Or not yet?
Say that she's still struggling.
I got in. There is one more person I think struggling. I just got in.
Oh, this is Star, right?
Yes.
What's your name here? So
Yeah, I'm just gonna put
Nida.
my,
Okay.
yes,
Okay.
Nida. That is my actual name.
Who's also suffering? Mr. T, is she here or not? Okay. Ask the group. Okay, so is Nefertit with us in the group or not? Sorry guys to disturb, I just want to make sure that I added her. Nefertit. Okay, yeah, she is. Okay. Let's continue. Okay, now let's talk about the odds ratio and the relative risk. So for the odds ratio and relative risk, this is also one of the simple things, right? It's very simple, but they can play like a lot, like with the wording of the questions, especially as I mentioned to you like before, especially in step 2 CK. You think that you understand the question, and the question seems to be easy, like, but the things that they are asking you about, it seems like sometimes you don't know really, is this the exposure or the outcome? Because we get used like usually the exposure, we know that the exposure is usually like the examples that we got used to, it will be like something like smoking, something like oral contraceptive pills, something like chemical waste. This is the things that we are always like thinking about and see examples about. And the outcome, it will be like a disease such as cancer, MI, something like that, right? But sometimes they give you like the exposure and the outcome, they give you both are like weird things. Like for example, hysterectomy, they will tell you the association. There was a question in 2CK about hysterectomy, the association between hysterectomy and what was it, the other thing, hyperlipidemia. So if I just told you like in general without give you any more information, the association between hysterectomy and hyperlipidemia, like it will be kind of weird to understand which one is the exposure, which one is the hyperlipidemia. It's not like in the same format that we get used to, like this exposure will be one of these. So just understand when you're reading the questions, when you come up to these kind of questions about, especially about the odds ratio and the relative risk, or the case control studies and the cohort studies, especially if it is a prospective cohort, it's kind of okay. But retrospective, this is the one that you will find very difficulty in differentiating it between, making a differentiation between the retrospective cohort and the case control. Like for me, I was like, it's easy. Like if you're going back and you are looking for the exposure and then following up if the disease developed, this is retrospective. If not, if you have the disease status, this is odds ratio. Yes, this is in general, it's right. But when you come and practice more questions, you will see that there are some questions that you will struggle a little bit to know which one they started looking for and what was the outcome that they were looking for. So I'm not saying that it is difficult, but I'm just saying practice more questions, because not just by doing one question and doing it right, you will feel, okay, I'm familiar and I know the concept of this. No, when you practice more questions, you will be surprised that sometimes you are mixing which one is the exposure, which one is the outcome. So, so you need to know that we know that in case control studies, like what are the, how are they asking questions about case control? So if I want to ask you a question about case control study, I can ask you, for example, I can give you a case scenario, just sentences, like one paragraph, tell you that an investigator did a study. He wants to know the association, and I like always, when I talk about case control, I like always to talk about the spina bifida and the, let's say, the incidence. So you want to know the association between the spina bifida and the so the incidence. So this is an investigator. He wants to know the association between two. So when you read the question in Biostat, I always also say, this is, I don't know how is your technique in solving the questions, but especially in Biostat, always make sure to read the answers, not read them, waste time, just, have a quick look at them, skim through them. Because when when you look at the answers, you will, this will help you, will guide you what to look for in the answer. So you will eliminate things, like you will focus on things, especially if there are numbers, and you will eliminate things when you are reading the question. So just looking at the answers before you go, especially when it's talking about study design, if it's talking about calculating the odds ratio, because sometimes odds ratio, they might ask you to calculate it and get the last result, which is 1.6, for example. Sometimes they will just give you, they want just the numbers, like, for example, 10 over 6 times 5 over 3. They just want this. So you will not waste time doing the calculation and having the last number. So you will know that if you skim through the answers first, when you read the question, you will be more comfortable that you're not going to do any calculation. So for the case control, again, this is, we said, number one, I can give you a case scenario, and then I can tell you, like the investigator went to those mothers who have spina bifida, and then he asked, there are two ways I can tell you. I can tell you, he asked the moms who took NSAIDs, and I can tell you, he looked into the medical records. So this is the two ways always the questions are formatted in the case control. He might go and he will tell you that he went to mothers with spina bifida and also mothers without spina bifida. So if there has to be cases and control, cases with the disease. control without the disease. Okay, so without. So he went to them, and then he asked this group, do you have kids with spina bifida? Do you have kids with spina bifida? These yes, these no. And then they ask each group, did you take NSAIDs? Yes, no. Did you take NSAIDs? Yes, no. And then you will calculate the odds ratio. But here in the question, you might see that he asked them, which means he interviewed them or distributed surveys for them, or he might just went to the medical records and checked in the medical records. So this is very new, especially in step 3, we didn't notice this difference, because usually if you go to them and ask them, this is the one that you have a risk of having recall bias, okay, or what we call, I think we were calling it, which is one type of the measurement or information bias, okay, or what we call misclassification of the exposure. Misclassification of the exposure. So see so far how many questions you can get in just case control. You can get what is the type of this study, and you can say case control. Okay. What are you gonna calculate here? And the answer will be odds ratio. And I can tell you what is the odds ratio, and I give you numbers, so you will have to do the calculation. Or I can tell you what is the odds ratio, and I give you just the equation, which is A, B, C, D, or the numbers without the final outcome. See, so far like 4 to 5 questions. And then the 5 question, I can tell you what is the most concerning in this case control study. So the most concerning, or what is the type of the bias. So it could be recall bias, or it could be measurement, which is one type of measurement bias, or what we call information bias, or it could be misclassification of the exposure. But the new thing that you need to add to your information is that this misclassification of the exposure and the recall bias, it doesn't, because before I thought that it is always with case control. But no, it's not always with case control. It's always with case control when you interview the patients. Because when you interview the patients, especially those who have the disease, they will tell you, yes, we used NSAIDs. So they will give you more, like they will over-report the use of NSAIDs. While those who don't have the spina bifida, because they're not like, they don't have it, so they will not even think about it. So they will not remember. Even if they use it, they will tell you, no, I don't remember that I used it. So you will have wrong information because the patient doesn't remember, or because especially those who have the disease, it's like when you want to find the reason for what happened to you, why this is happening to me. And I told you, like, maybe it is because of this. What are you going to say? But you will say, yes, maybe it is because of this. So those who have the spina bifida, they will report more, while those, even if they used it, they might tell you, no, we didn't use. So the end result that you will have wrong information because they don't remember. And this is usually it happens when you interview the patients. But if you are looking at the patient's records, there will not be like recall bias or misclassification of the exposure, because you're simply just going to the record of the patients and you are checking, and this is another way of asking the question. When I'm asking you about the case control, like usually when you go to the records, you have to read to make sure when you are reading the question, which one you had first. So if I told you I went to the patient's records and I checked those with the disease and those without the disease, and I was looking for what is the thing I was looking for? I was looking for their exposure to the NSAIDs. So in this case, you are just reading in the records. If this patient used the NSAIDs, if this patient was exposed to chemicals, if this patient was a smoker, was he alcoholic? So here, there is no, like, I'm not asking anyone. There is no one is forgetting to giving me the information. Maybe there could be like a misclassification, but it's not going to be as much as when you are interviewing the patient. Usually misclassification of exposure and recall bias, it happens when you're interviewing, but when you're looking at the patient record, usually exclude these two. Maybe there is something else the question want to ask you. Okay. So this is in terms of the case control. So we said usually you will be confused with the, where is the mouse? Why I don't see it? you will be confused the other way. Like, see, like around 7, I can ask you 7 questions just about 7 totally different questions just about the case control. Coming to the thing that is confused with it, which is retrospective cohort study. So in cohort, what happened in cohort? In cohort, you will have first, you will know, or what we call identify. You're identifying. You're not doing anything. You're not telling this patient, okay, you go smoke, you don't go smoke. You take this medication, you don't. No, you are just identifying. You're interviewing people and you're asking them, are you smoker? So you are identifying the exposure status. So from the beginning, you will know what is the exposure status. So if he said yes, this will be exposed. If he said no, this will be unexposed. And then both of them, you're gonna follow them over the time. This time it could be 5 years, it could be 10 years, it could be months. And then you just observe. You don't do anything. You're not doing like any active role here. You just observe. And then you will see how many people from the smokers developed the lung cancer and how many people from the non-smoker group developed the lung cancer. So let's say you have 60 smokers and 20 out of these 60 developed the lung cancer, while you have 40 non-smoker and 10 developed the cancer in this group. So you will calculate this risk and then calculate this risk and then divide both, which we call E divided divided by A plus B, and C divided by C plus D. And then you will divide this by this, the outcome here, you will divide it by the outcome here, which is the exposed divided by the unexposed. And then you will get what we call the relative risk. So the relative risk here, it would tell you like what is the risk of getting lung cancer in the smokers compared to the non-smoker. And if it is high, like if it is more than 1, it means the risk of getting the cancer in smokers is more than the risk of getting cancer in the non-smokers. So this is the relative risk. While in the odds ratio, when you translate the data, the odds ratio, like there was yesterday, so question 2CK, they give you everything about the odds ratio, the calculation, everything. Like they give you all the information in the question. They told you that this is a case control, and the investigator did this and that, and the odds ratio was like this, and the p-value was like this. And then they give you what the student or the investigator, what was his conclusion, what was the conclusion. And then they told you what was wrong with this study or with this conclusion. When this student or investigator come up with his conclusion about the odds ratio, the way he put the sentence was wrong. So he said that there was like, let's say, he was talking about OCP, okay? I don't remember what the question was talking about, but let's say that it was about OCP and breast cancer, okay? And everything was fine, but when he translated or come up to the conclusion, he told you that he translated the odds ratio that those who used OCP, they are having more risk of developing breast cancer, something like that. This interpretation is wrong, because here it seems like you are talking about the relative risk. You're not talking about the odds ratio. Relative risk, you're saying if you are exposed, what is your risk of developing the cancer? But in odds ratio, it's the opposite. It's like if you are having the disease, what is the odds that you have been exposed to this exposure? So it is the risk of being exposed. It's not the risk of developing the cancer, because you already know the status of the cancer. But you want to know if you're having this cancer, what is the odds that you have been exposed to that specific thing? So that's why I always tell you, just understand the interpretation of all these, all these ratios, the odds ratio, the relative risk, the hazard ratio, the number need to treat, anything you calculate, understand how you translate the data and how you read the data to other people, whether for the exam sake or when you do the residency or presenting a paper. So this is in terms of the odds ratio and the relative risk. And then for the relative risk again, or for the case control, we said first you will have the exposure in cohort, and then you're gonna see what is the outcome, right? What is the outcome? So this is for the prospective. Prospective, it means you are following the patients over the time, following them to the future. But for the retrospective, you will also look in the medical records. So before, like long time ago, whenever I see medical records, I would just pick the case control, which is wrong. Case control is not the only one where we go and look for the records. You can look at the patient record, but you can, from that, you can do a case control design. And you can also do retrospective cohort, or you can even do cross-sectional sometimes. Cross-sectional, usually you do it at that moment, but I'm just giving like, as an example, I can simply go to the medical record and simultaneously, I will see who is having, for example, family history of diabetes and who and also having diabetes. For example, type 2. At that moment, I will just see, I will measure the exposure and the outcome at the same time, because this is the definition of the cross-sectional. Cross-sectional, there are three names for it, right? Cross-sectional or snapshot study or prevalence study. And in this, you measure the exposure and the outcome at the same time, simultaneously. It's not like the cohort. In cohort, you measure the exposure and then you go check for the outcome. And it's not like the case control. In the case control, you know the exposure, you have it, you have the outcome, and you go back to look for the exposure. For the retrospective, you will go to the medical record and you will check in the question when they tell you that you are looking in the medical record. What is the first thing that you have? What is the thing that you identified? Did you identify the cases and the control? Did you say I do have Crohn's disease and no Crohn's disease and I was looking for the exposure? This will be the case control. No, here you will identify the exposure. So you will go to the medical records, you will see who is a smoker and who is not a smoker, and you will follow up, like in their medical record, you will read their records over the years to look for the incidence in the past. They already have the cancer. They do have the cancer at that moment. But let's say you went back to their records from 2000, and you will keep reading their records for 5 years, and you will see in 2005 who developed the incidence of the disease. So always in cohort, we're looking for the incidence of the disease. For case control, we're looking for the exposure status. For the cross-sectional, we are looking for the prevalence of the disease. So it's very simple, and I'm sure that all of you know all these, concepts, but you need to do more questions, because sometimes still you get them wrong if you don't read the question right. What else they can ask in the I saw a question also yesterday. It was for the retrospective. So they give you MI. Can you imagine? They give you MI and they give you schizophrenia. Can you imagine? Like, this is like, it's very for me, like, it took me a time to understand. Okay, you went back to the medical record numbers, to the medical records of the patients, and which one you had first? Did you have the status of the schizophrenia and no schizophrenia as the disease, and you were looking like for MI to be the exposure, like which one happened first? Was it like I was looking if you have in the past MI, you are at higher risk of developing schizophrenia, or the opposite? If you had schizophrenia in the past, what is your risk of developing MI, like a case control? And like, if you read the question like carefully, you will find like or in a right way. If you write the question in the right way, you will see that first they were looking, they say which one was having schizophrenia, like this patient has schizophrenia and this patient doesn't have schizophrenia, he doesn't have it. And then in the medical records, all this was, you were looking in the medical records of the patient, and then you followed these medical records to look for the incidence of the MI. for the incidence of the MI. So here it was a retrospective cohort study, and in this case you will calculate the relative risk. So I think the question was asking what is the type of the study, and you will get confused between is it a case control if you don't know which one, like which one you determine first. So here we determined first the exposure, which was the schizophrenia, and then the MI was the outcome that I was looking for. So here we were looking for an outcome of the disease, not for the exposure. And then the answer was retrospective cohort study. And another thing for the odds ratio and for the relative risk, we know always just make sure that when you not only in the odds ratio, in all biostat, you put the disease status in the top when you do the calculations, and you do the exposure status, or sometimes the test when we are talking about type 1 error, type 2 error, all these things, and the power of the study, the null hypothesis, always the test here, the exposure here, the disease here, or the test here, which is the new test, and what is happening in real life, or the gold standard test, or the confirmatory, gold standard or confirmatory test. Like if I told you like urine analysis versus culture. So culture is more accurate. It more reflects what is happening, what is really true, right? So culture, it will be here. So the thing that is happening or true, it's in the top, whether it is disease and exposure, whether it is the test and the confirmatory test, or whether it is a new test and the standard test, or a new test and what is really happening in life. Okay, so disease status here, exposure here, you will do plus minus, and then always it's like that. A is here, B is here, C is here, and D is here. And then simply, if you are, always this, what does this represent? The total of this, it represents the disease status. So all these people in this column, all these people, they have the disease. They do have the disease. All these people in this column, they don't have the disease. And then your test or your exposure, your test, if the test comes back positive and you do have the disease, this is what we call true positive. If your test come back negative and you do have the disease, this will be false negative. Same thing here. These are healthy people. If you get them up, if your test tested them positive, this will be false positive. And if you're testing them negative when they don't have the disease, this will be true negative. So always true positive here, true negative here. When we talk about the disease versus the exposure, same thing. If you were a smoker and you develop the disease, this will be here. If you are a smoker, positive, and here negative. If you are a smoker and you develop the disease, you will be in this column, in column A. If you are a smoker but you did not develop the disease, you will be in column B. If you are a non-smoker, because we said here the exposure status, if you are non-smoker and you develop the disease, you will be in column C. And if you are non-smoker and you didn't develop the disease, you will be in column D. So if I ask you, what is the relative risk? What is the relative risk here? The relative risk, it means how many people develop the disease, right? Among the exposure, and how many people develop the disease among the non-smokers, right? When we do it before, A divided by A plus B. So here I have 10 people, like among, let's say here 10 and 10, and here 5 and 10. So I have, how many people are smokers? I have 20 people who are smokers, which is A plus B. This is 20 people who are smokers. How many of them have the lung cancer? It will be 10. And then here the non-smokers, we have 15 people who are non-smokers. How many of them develop the lung cancer? It is 5. So this is the risk alone in the smoker group. When you do it, it will be 0.5. This is the risk in the smoker group. Someone is here, Serena. Okay. So this is, if I told you what is the risk of developing cancer in the smoker group, you will just give me this number. You will give me just this calculation. This is the risk of the smoker group. If I told you what is the risk among the risk of having cancer in the non-smoker group, it will be only this. If I told you what is the relative risk, which means the risk of having cancer relative in the smoker group relative to the non-smoker group, you will divide this divided by this. So this will be the relative risk. So it will be 0.5 divided by 5 divided by 15, whatever it is. Let's say 0.3. Let's say 0.3. So this will be the final relative risk. So you will do another way you can say it, exposed divided by the unexposed. So, but when it comes to the odds ratio, same thing. You will do this table, and you will do A, B, C, D. So the odds ratio here, we have the disease status, right? And we have the exposure status here. So I want to know if you do have the disease. If you do have the disease, what are your odds of being exposed? And if you don't have the disease, what are your odds of being exposed to the disease? So the answer, it will be so you will focus here first. You have the disease. If you do have the disease, which is A, what's your odds of being exposed? So it will be A divided by C, right? A divided by C. If you don't have the disease, it will be divided by, which is this one. This is not having the disease. It will be B divided by D. So this is the odds. So the odds of being exposed, which is this one, being exposed, if you do have the disease, it will be A divided by C. C, you're not exposed. So it will be A by C. And the odds of being exposed here, and you don't have the disease, in those who don't have the disease, it will be B divided by D. Another way you can say it, like simple math, if you do like this, it can be AD divided by BC. AD divided by BC. So this is the odds ratio. And that's why, like, if sometimes they can give you, if you look in the subjective view, they can flip. So they can give you the table ready, and they do the exposure status here and the disease status here. So it's up to you. If you want to memorize it, you can memorize it, or if you want to reorganize the table, that's also fine. So if you're gonna reorganize the table, you have to reorganize it and make the disease status up and the exposure status down. The other way, you can just simply, like, if you're gonna do this one, the AD divided by BC, you have to reorganize the table. You have to reformat the table in the correct way. You cannot do it unless if you reorganize it. But if you want to do the division part, you can just, instead of saying A divided by C, just say A divided by B and C divided by C. So just say A, you will get the same number, A divided by B divided by C divided by A divided by B, C divided by C. So by D. So this is if you want to save time. Just do it this way. If the exposure status was flipped with the disease, instead of saying A by C, B by D, just say A by B divided by C by D. But if you're gonna do this way, which is AD divided by BC, you have to reorganize the table. Okay. Okay, so correlation, we know about the correlation. Correlation, you have, it stands when you say correlation coefficient, we know what are the questions that you can get in correlation coefficient. I can give you just values. First of all, you have to know what does correlation coefficient mean? What does it show you? When I give you a number of correlation coefficient, what does it mean? It shows you two things. It shows you the strength of the association between two things, and it shows you the polarity of these two things. So it shows you the strength and it shows you the polarity. So for the strength, you will say this is a strong association or weak association. The polarity, it is positive association or negative association. So whenever we know this simple thing, you have 0 here, and this is the positive and this is the negative. So positive +1, negative +1, -1. So whenever you are close from the 0, your association is weak. When you are getting to close to the 1, your association is strong. Same thing in the negative side. Close to zero, you have a weak negative association. So here strong positive association, here strong negative association. So whenever you are approaching the 1, in either direction, it will be strong association. But you will say this is strong positive association or strong negative association. So if I give you 0.5 plus 0.5 versus plus 0.8, which one is stronger? Of course, this one, because it is closer to 1. If I, same thing here, if I give you minus 0.5 and minus 0.8, which one is stronger? Of course, this one, because it is closer to the -1. This is the most important thing. And the other the other way they can ask you about the correlation coefficient, what does it mean? So if I give you folic acid and colon cancer, the association between folic acid and colon cancer, okay? And I give you not colon cancer, let's say folic acid and hemoglobin, okay? Or iron and folic acid and hemoglobin. So let's say iron level, okay? Iron level. And the other example, I give you hemoglobin A1C, okay, hemoglobin A1C, and hemoglobin A1C and anything in your blood. What is in our blood that could decrease this amount? Anything. Let's say vitamin C. Anything. Someone is here. Neuro. Okay. So if I give you, did I admit him or not? Okay, so if I give you anything in your blood, okay, to association, and I want to know the association, and I told you that the association between iron and hemoglobin, it was, I give you R equal 0.6, positive 0.6, okay? And I told you, what is this association? What does it mean? I can tell you what does it mean. And the answer will be, as the iron increases, the hemoglobin will be increasing. Why? Because it is a positive association. Positive association, I can give you like a question like this, or I can give you, tell you here is hemoglobin and here is the iron. And I tell you like this, I give you an association like this, which is positive linear association. See? As you are increasing the values in the hemoglobin, you're increasing the values of the iron. So as iron increases, the other one increases. Or I can give you, and also I can ask you, is it positive, negative? So you will exclude all the answers that is negative. If I told you this example or the similar example, if I give you negative, what does this mean? This means that I can give it to you in a format of a question, or I can give it to you like this. So what does this mean? It means when the iron is high, the hemoglobin is low. Same thing. When you are decreasing the iron levels, the hemoglobin is increasing. So as one increases, the other one is decreases, and vice versa. As one decreases, the other one is increases. And the other way, as you notice, they ask these questions. They can just give you, one is like distributed like that, one is distributed like this, another one is distributed like this, and another one it's like this, and maybe sometimes they supplemented with the R number, so I can give you 0.4 here and 0.3 here, and I will tell you which one is the strongest association, or I tell you translate this data, or as in step 3 that they give you, with it they give you also the p-value. So anyone with the p-value that is not significant, you would not consider it, and you will pick the one that is having the highest, strongest association, which means the one that is having the best will be the one that is having linear association. Linear association, it will be the strongest because it is closest to 1. And another way they ask this question, there was a question they're asking about the positive predictive value, which one is having the lowest. So if you're having 0.3 versus 0.8 correlation coefficient, this means that 0.8 has strongest positive predictive value, while this one will have the lowest or the highest, not strongest, the highest. So this one will have the lowest positive predictive value. So correlation coefficient, when it decreases the positive predictive value. What else in the correlation coefficient? There is also something else in the correlation coefficient, which is the, let me just remember it here. I think we call it the, anyone remember the wording when we do the square of the R2?
Variability in one component.
Yeah, but what do we call it? We call it
coefficient
of differentiation, something like that, right?
Variation coefficient.
I think coefficient variability.
Just give me a minute. No, we call it of determination, coefficient of determination. Here we call it coefficient of determination. So what is the coefficient of determination? The example I give you, if I tell you that the R equals 0.6, R equals 0.6, and this is the relationship between the iron and the hemoglobin, for example, and I told you what is the coefficient of determination. Coefficient of determination, it will be the square of this R, and the square, it will be 0.6 times 0.6, so it will give you 32. What does 32 means? It means that 30% of the variation in the hemoglobin was explained by the iron level. So 64% of the variability in the hemoglobin, it was explained by the by this iron intake, for example. So how do you explain it? You will say that 32 or 64% of the variability of this one, of the variability in the hemoglobin, it was explained by the iron intake, for example. That's how you read the coefficient of determination. Just 1 second. Okay, so this is the coefficient of determination, and then we have another important concept. You can review it from the subject review, and also there is another question from the from step 3, okay, which is the attributable risk. This is very important, the attributable risk. Attributable risk, there are 3 ways they can ask you. Okay, they can give you the example and they will tell you what are you gonna calculate. So you need the attributable risk, and I can ask you what is the attributable risk, or I can ask you what is the attributable risk percentage, or I can ask you what is the attributable risk percentage in the population, which is the population attributable risk percentage. For the attributable risk, it's simple. It's simple. You will just take we said the exposed minus the unexposed. So if I'm telling you that, if I'm comparing like treatment and a control, and this treatment seems to be harmful, or let's say smoking and non-smoking, so and lung cancer. So I want to know what is the attributable risk of lung cancer in these smokers group. So I will just take the exposure minus the control. So it will be exposure minus the control. So this will be simply the attributable risk. But if I want the attributable risk percentage, this I will take the exposure minus the control, and I will divide it by the exposure. And it's good to know, it's important to know which one is the exposure, which one in the control. But for the exam purposes, just take the big number and minus it from the small number and divide it by the big number. Okay, so let's say here 0.5 minus 0.3 divided by 0.3, simply. So this will be the percentage. And the way you read it, it's you're saying that for the attributable risk, you're saying that those who are smoking, their attributable risk of getting the cancer is, let's say, 10%. But when you do the attributable risk percentage, okay, now you have a smoker, right? You have smoker and you have non-smoker. Those who are smokers who develop the cancer, and there are some also here who develop the cancer, and then you calculated the attributable risk. But when you are calculating the attributable risk percentage, you want to know in this group who were smokers and who develop cancer, this cancer. You want to know these cancer patients, what is the percentage that their cancer was attributed to smoking? Because the percentage you got, maybe you got 50%, right? They have the attributable risk, it was 50%. You want to know how much of this 50% it was attributed to smoking. It could be due to smoking, it could be due to maybe other factors, alcohol, any other factors that causes the cancer. So attributable risk percentage, you want to know what is the percentage of this disease that is attributed to the exposure. This is the definition of the attributable risk percentage. So in the question, they will tell you what is the attributable risk percentage among the exposures. Usually the question says exposure. If they told you among in the population, they will tell you among the population, or they will tell you among all the study participants, So in that case, it's like the equation seems like complicated, but when you understand it, it's going to be the same equation as the attributable risk percentage equation. So the attributable risk percentage, we said exposed, right? And this is the importance when I tell you, understand the definitions. When you understand the definition of each thing, everything, all the equations and everything becomes easy. So for the percentage, we know that we're doing the exposed minus the unexposed divided by the exposed, right? So when it comes to the attributable risk percentage in the population, so you don't want what is the percentage of developing this disease in the exposure. In the question, they didn't tell you in the exposure. They told you in the population or in all the study participants. So instead of saying exposed, you will say the risk in the population. So it's not going to be the population risk. It's not going to be the exposure risk. It will be the risk in the population. So risk in the population minus the same thing. You want to keep this the same. So you will minus the unexposed. And then you will divide it by the risk in the population. Same thing. So it is the same equation, but because the question, they don't want you to calculate the percentage among the exposure group. They told you among the population or among the all study participants. So just replace these two with the risk in the population. So it will be population minus.
Huda, can you repeat this calculation, please? Just
Yes.
this one. Yeah, population one.
Yes, so we said attributable risk percentage, its equation is exposed minus unexposed divided by exposed, right? We agree on that. Or the big number minus the unexposed, the small number divided by the exposed, by the big number. When I'm asking in the question, they can tell you what is the attributable risk percentage in the among smokers, which is the exposed group, right? Among smokers, which is the exposed group. So among smokers, it means you will do this equation, which is you will calculate the risk among smokers, and then you will calculate the risk among non-smokers, and then you will minus this from this divided by this. This is simply, when they ask you what is the attributable risk in all study participants or in all population, which means all study participants means the smokers and also the non-smokers, right? Also the non-smokers, or all the population, same thing. In the population, you have smokers and you have non-smokers. So the equation, it is the same. It is the same, which means exposed minus unexposed over the exposed. But here, they don't want you to calculate only in the exposures. They want among the whole population. So you will replace it with the population. So you will calculate the risk in the whole population, which is the big number, minus the unexposed, which is the same as here. We don't change this part, divided by the risk in the population. So here exposed minus unexposed divided by exposed, here population minus unexposed divided by the population. So this is, we call it the attributable, the population attributable risk percentage. And then if we want to apply that in numbers, we have, I can give you like the question in the subject review, I can tell you we have smokers and non-smokers. And I tell you here, the non-smokers number is 40 and the smokers number is 60. So this is the number of people who are smokers. This is the number of people who are non-smokers. And I tell you, among people who are smoking, 30 develop lung cancer. And among people who are non-smokers, 10 develop lung cancer. And then I will ask you what is the attributable risk percentage. So the attributable risk percentage, simply, you will calculate the risk here, whether I give you the question in sentence or inside the table, the information was inside the table, because I saw a question like that, it was a table, and you have the risk only in each group. For example, the cancer and here. So you will see that you have here 30 and you have 10. And then you don't know what is the denominator. You don't know what is the number of the smokers among this group. So you will have to go back to the question and see in this group how many smokers. So you will find the 60 here and the 40 here inside the question itself. So here they give you only how many people develop the outcome, which is the cancer. So in this case, if they don't give you the risk right away, if they just give you this, look for the denominator, because you have to do to calculate the individual risk first. So again, I don't want to confuse you with this, but here I told you, like in a question, simple question, that I have 60 smokers and I have 40 smokers. Among those who are smoking, we have 30 cases of cancer, and among those who are not smoking, I have 10 patients who develop the cancer. And I ask you, what is the attributable risk percentage? So for the attributable, first calculate the risk individually, because sometimes I might give you the risk right away. I will tell you this is the risk among smokers and this is the risk among non-smokers. If I don't give you, you have to calculate the risk individually. So the risk of having cancer in the smokers, it is 30 divided by 60, which will give you 0.5. And the risk among the non-smokers, it will be 10 divided by 40. And this is common sense. You see how many people are non-smokers. This is the denominator, same thing. How many people are non-smokers? This is the denominator. Among them, how many develop the outcome, which is 30. Same thing, among them, how many develop the outcome, which is 10. And then when you divide the 10 divided by 40, how much you will get? I think 24, right? 25, I mean. I'm not sure though. So let's say that it is 25, okay? So here you're having 50% and here you're having 25%. So 50% of people who are smoking develop the cancer, or at high risk of developing the cancer, while 25% in this group, they develop in the non-smoker, they also develop the cancer. So this is just the risk. This is when I ask you just what is the risk among each group. And then to calculate this, you will take the big number, which is the exposed, minus 0.25 and divided by 0.25. So 0.25, 0.5 minus 0.25, it will give you 1. And then 1 divided by 0.25, I think it will give you 4, or whatever number it will give you. So this, let's say 4. So this will be the attributable risk percentage. So first calculate the individual risk, if they didn't give it to you already in the question. Second, you will do the equation, and you have to know what the equation is. So the equation, it will be big minus small divided by big. So this is in case if I if I give you this, information, and I told you what is the attributable risk percentage. What about, so, and when in the question, I will tell you in the exposed group or among smoker, what is the attributable risk percentage among smoker? That's how I am gonna say it. But what if I told you what is the attributable risk percentage among the attributable risk percentage among the whole study population, among all study participants, okay, all study participants. So same thing, I will calculate the risk here, okay, but here all study participants, it means my denominator will include the smokers and the non-smokers. Same thing with the numerator. So I want all. So when I calculate the risk, I will not calculate it individually. So I will see how many people develop lung cancer. How many develop lung cancer? We have here 30 among the all study participants. We have 30 here and 10 here. So it will be 40. So these people among all study participants, they develop the cancer. How many people among all of them are smokers and non-smokers? Because I want all. So we have the population here, it will be 60 plus 40, which is 100. So this is the risk in the population, which equals 0.4. Now apply the equation, which is the same. The same, it means it will be population risk instead of the exposure group risk, population risk minus unexposed divided by the population risk. Simply like that. So the population risk, which is, we replace it by the exposure. Before, we just did this number because we want among smokers. So we took only 0.5. Here, no, we want the whole population, smokers and non-smokers. So it will be 0.4 minus the unexposed, which we just calculated, which is 25, divided by the 0.4. So this is the attributable risk percentage among the population. So this is generally speaking. And then in step 3, this is simply speaking. And then in step 3, the problem, if you go back to the question in step 3, just look it up, the attributable risk percentage among the population. The problem in that question that they added to you, they gave you the prevalence of the disease. They give you what is the prevalence of the disease. So, sorry, the prevalence of the smokers. They told you in this population, there is 0.5 prevalence smokers. So which means the other 0.5 are non-smokers, right? Non-smokers. So you are still gonna do the population risk minus the unexposed divided by the population risk. But when you calculate the population, when you do the risk among smokers and non-smokers, when you do the risk, which in this example, we said like 3 divided by 6, 30 divided by 60, and this is the smokers, and 10 divided by 40, right? When they did this calculation, you have in the smokers, you will multiply the smoker risk times the prevalence of the smokers. And when you do the risk among the non-smokers, you will multiply. So this number, let's say it is 0.5, right? So you will multiply it by the prevalence of the smokers. And here it was 0.25. So you will multiply it by the prevalence of the non-smokers. So if I told you the prevalence was 70, so here it will be the non-smokers, it will be 30. So you will multiply this 0.7 and 0.3, you will multiply it by the risk of the smokers. So the risk among the smokers that you calculated, you will multiply it by the prevalence of these smokers. And the risk among the non-smokers, you will multiply it by the risk among the non-smokers. And this is the only addition. That's why that question, it seems difficult or more complicated, but it's not. It's exactly as this. But when you are calculating the individual risk, you will multiply the risk in the smokers times the prevalence, and the risk in the non-smokers times the prevalence. This is the only addition that you will add in that question.
Sorry, so in just both the groups, we have to keep the fact that like what the prevalence is, like 0.5 each time.
In both groups, yes, when they give you in the question the prevalence. In that question, they didn't tell you what is the prevalence of the smokers. They give you the prevalence of, they didn't give you of the non-smokers. They told you the prevalence of the smoker, it is 0.5. That's it.
Oh.
And in that question, it was three items. Like they give you the prevalence in the first item, and they ask the attributable risk percentage in the last item. So you will have to go back and check what is the prevalence. So it was 3-item questions. The first one, I think they asked about the relative risk. And then the second one, they asked about the attributable risk percentage. And the third one, they asked about the attributable risk percentage in the population. Another thing here, if they ask about the relative risk, this one, it will be easier because as we said you can do exposed minus and exposed divided by the exposed, or the other way, since you already calculated this, if it was 4, for example, you can, another calculation for it, it will be relative risk minus 1, right, divided by the relative risk. So this is another way for calculating the attributable risk percentage. For the similar example I give you, if I give you 10 out of 30 in the non-smoker group, and you have 40 out of 60 develop the cancer in the non-smoker group. So if I'm asking what is the relative risk of having the cancer among the smokers compared to the non-smokers, so we'll do 40 divided by 60, and then over 10 divided by 30. So this will be the relative risk, which is A divided by A plus B, and here C divided by C plus D. Okay, what is the time? Okay, still we have time. Okay, so let's do, this is very important about the null hypothesis. Null hypothesis, I can tell you what is the definition of null hypothesis. Simply, you can have a question just like that. What is the null hypothesis? So null hypothesis, this is, I understand it, it's like the default. So the default, like in life says that there is no association, no association. So this is the null hypothesis. Null hypothesis always that there is no association. Anything you want to prove that there is an association, anything that you can think about, smoking, lung cancer, NSAIDs, peptic ulcer, anything, the life says that the theory of life says that there is no association. That's why you do a study. Why are we doing studies? Why do we do studies? We do studies because we want to prove that there is an association. There is an association between an exposure and the outcome. So we want to prove that this null hypothesis is wrong. That's what we want to do. We want to reject it. We want to reject this null hypothesis. That's why always the presence of an association, if you succeeded to prove this association, it means you succeeded in proving or in rejecting the null hypothesis. If you failed to prove this association, it means you failed to reject the null hypothesis. You failed to reject it. Why? Because it was true. You failed to reject it. So the null hypothesis is true, which means there's no association. So always understanding like that. Life says that there's no association. Now I'm doing a study. I want to prove that there is an association. If I was able to prove this association and I get a statistically significant association, it means I was able to reject the null hypothesis, which says that there is no association. If I fail to prove, it means I failed to reject this null hypothesis. And then for the going to the association. Now, in your study, you're saying that you're having an association, right? You want to say that there is an association. So you might have 3 outcomes after your study. 3 outcomes in your study. You might be able, for the power, what is the definition of the power? The power, it's all about reality. Power, it's all about reality. So reality says that there is an association. So this is the power. And you will get the power, your study will be powerful if you were able to prove this association that present in the reality. So the power of your study is your ability to detect this difference or this association in reality. So if in your study where you want to prove that there is an association, if you were able, if let's say here the study and here the reality. So if your study was able to prove this association, statistically significant association, and in reality, this association truly present, so this is the definition of the power. So what is the definition of power? It is when you are proving that there is, saying that there is an association and proving that there is an association, when in reality there is one. It is truly exists, truly it exists. The other outcome that you can have is that you will prove that there is an association. Your study will show that there is an association, but in reality, this association does not exist. So you have a treatment and you will say this treatment treats celiac disease. It is effective in treating Crohn's disease, any disease. And in reality, it is not effective. Your treatment is not effective. So what is this? This is type 1 error. This is type 1 error. And 1, it is 1. And it means the first letter, which is alpha. A is the first letter, which is alpha. This is type 1 error. And then you have if your study says that you don't have, if your study couldn't find an association, if you said that this medication, I tested it and it does not have side effect, you're saying that there is no association between ACE inhibitor and angioedema, let's say, but in reality this association is existing. So always I told you power, it's about the reality, right? So the power, whenever you see that reality says that there is an association, this is power. So this is power, right? But in this power, your study was not able to prove this association. Your study says that there is no association. So this is the beta error. So this is beta, and beta always comes with the second letter, right? So type 2 error. And that's why—
Dr. Huda, can you explain this last point one more time, beta error?
Yes. So beta error, your study says that there is no association. Your study says that there is no side effect for the medication. But in reality, there is a side effect. There is an association between the exposure and the outcome. So this is type 2 error. What is the definition of type 2 error or beta error? It is saying that there is no association when in reality, there is one. An association exists, okay, or a difference exists. So this is type 2 error or beta. I was trying to relate it to power because I told you always in reality, when in reality there is a true association, this means this is related to the power. So if in reality there is an association and your study was able to prove it, you're having a strong power or your study is powerful. But if reality says that there is an association and you were not able to prove that difference or an association, this is beta error or type 2 error. And that's why the equation of the power, it is 1 minus beta. So you will remove this beta from your equation to detect this power. So that's why power definition or the equation of the power, it will equal 1 minus beta error, because beta error was not able to detect this association that truly exists. So here is beta. So you will remove this in order to detect the power. So if your study has 20% versus another study which has 40% beta error, so which one is more powerful? Is it 20% or 40%? Of course, 20%. Why? Because 1 minus 20 equals 80%. So the power of this study is 80%. While the power of this study to detect the difference, it's only 60%. So this is like a general outline to understand all the things about the power, type 1 error, type 2 error, and also the null hypothesis. And then if you want to understand it, in the way of like in the format of table, we said always you have reality here and you have the test or not the test, your study result or your study test. So, and then you have the null hypothesis, right? The null hypothesis. So if this is reality says that there is an association, or reality says that there is no association. So if your test or your study was able to find a statistically significant association, when in reality it truly exists, this is the power. This is good. This is the thing that you want. This is the thing that you want. You want to prove that there is an association when in reality it truly exists. If your study shows, let's continue on the positive side. If your study says that there is an association, but in reality there was no association, this is alpha error. You call it alpha error. It's not alpha value, it's alpha error or type 1 error. So this is type 1 error, which when you say there is an association, but in reality, it does not exist. If your study was not able, here, when you're saying that there is an association and in reality there is one, here you succeeded in proving, in rejecting. You were able to reject the null hypothesis in this case. You were able to reject it because null hypothesis says that there is no association when in reality it truly exists. But here you rejected the null hypothesis. You said that there is an association when in reality null hypothesis was true. Here null is true. Null is true in reality because in reality there is no association, but in your study you rejected. So you rejected the null hypothesis when in reality it was true. Okay, here, if your study was not able to detect a statistically significant difference or an association, but in reality, this difference present or this association present, and we give the example of the side effect. If your study says there is no side effect, but in reality there is one, this is, we call it type 2 error or beta error. And that's why when you calculate the power, you will do 1 minus beta, which is this one. So the power, it's here, or it's here, the power is here. So when you want it, you will do 1 minus this one. You don't want this one in your equation. And then this one, we don't have a name for it, but here when your study says that there is no association, which means that you are saying, yes, there is no, you're not rejecting the null hypothesis. And in reality also, there is no association. So in reality also null hypothesis is true. And we don't have a name for this one. It's just a true conclusion that you will have, that you're saying that there is no association and in reality it's true. Okay, now we will come back to this will take us, or this one, it will take us to a better discussion about the p-value. P-value, always there is a misunderstanding that p-value and alpha are the same. They're not the same. What is alpha error? What is alpha value? And what is p-value? So alpha error and p-value, you can say that, okay, they are the same. But for the alpha value, usually this one, when your study said that there is an association, which in reality it does not exist, you can accept that. You can accept that you're saying, for example, alcohol leads to cancer, right? Leads to cancer. There is an association between these two. You can accept that this association, if your study proves that alcohol leads to cancer, you can say this is a true association, or you can say this association, maybe it happened just due to chance. It was due to chance alone. It was not a true association. You can accept that to up to 0.05, up to this level, to up to actually less than this limit. So up to 5%, up to less than 5%, you can accept that the association that you had in your study was not a true association. It was just an association that happened due to chance. You were just lucky that you have that association. You just get that association. It was not a true association. It was due to chance. You can accept up to this limit, less than 5%, to say that this association, it's not a true association, it was only due to chance. More than that, you don't accept it. And this is what we call here. We call it not the alpha error we call it the alpha level. So usually the alpha level Let me delete. Usually the alpha level, usually the default of it, it's less than 0.05. This is something for every study, almost generally speaking. This is the alpha that even if they didn't tell you in the question that the alpha level is 0.05, this is the default for the p-value or for the alpha level. It's always 0.05 unless if they tell you something else, if they give you another value. And this another value, usually it's less than that. So if I, then when you do your study, you will do your study and you will do your analysis, and then you will calculate the p-value. If your study shows that the alcohol, let's say alcohol, leads to the or is not leads is a wrong way, because we said always these things that we are talking, we call it's measures of association. You never say that this leads to this or this causes this or this leads results in this. We are talking about an association. If I said alcohol is associated with colon cancer or with lung cancer, and then I will calculate. So p-value, it's something you calculated in your study. So if you calculated the p-value and the p-value was less than this alpha, which is 0.04 or less, 0.04 or less, then you will say there is a statistically significant association between alcohol and the lung cancer. Why? Because the p-value that I have in my study, which I analyzed and calculate, it was less than the alpha level. What is the alpha level? It is the error that you are accepting, which means I'm accepting up to 5%, less than 5%, that this association, it was not a true association. It was a random association that happened due to error. Okay, sometimes they tell you, if I tell you my study was 0.04, now I'm gonna say that it is statistically significant, even if they didn't tell me what is the alpha. But if in the question they told you that the alpha level was, that you set the alpha significant level to 0.01, then this same level, with this same value, I will say that there is no statistical significant association. Why? Because the p-value that I calculated, it is more than the alpha that I set for my significant. Did you get it here, guys? So same result. If it is 0.04, I will say that it is statistically significant because it is less than 0.05. But if in the question they told me that the investigator set the alpha significant level at 0.01, this means this one is not statistically significant, because 0.04 is more than 0.01. Because in my study, I wanted to accept only 1% that my association was due to chance alone. If you get 4%, I cannot accept it.
So if in a question it's not mentioned, so we assume that less than 0.05 is
Yes, it's always 0.05, whether they regardless if they mention it or not. Not if they mention. If they don't mention, it's 0.05. If they told you this, then you will see. Don't say that this is statistically significant. Okay, and this will direct us to another thing, which is the power of the study, right? That's why we say the power of the study. What are the things? We have a table, right, in step 3 that talks about the power of the study. We have the power. There are 4 factors that affect the power of the study. We have the sample size, and then we have the effect size, and we have the last one, we have the alpha. See, it's not the alpha error, it is the alpha significant level. That's what we call it. And the last one is the variability. Okay, so you can, if I told you what is the effect of increasing the sample size on the power. So increasing sample size, it will increase the power, right? Why are you gonna increase the power of the study? Because you will be more able to detect a different, if this different is truly existing. So if in real life there is a difference or there is an association, if you're having a smaller sample size, you might not be able to detect it. And if you're increasing the sample size, you might be able to detect that difference or that association that truly existing in the real life. So this is in terms of the sample size. And then for the sample size, you will have what will happen. We said the power will increase. Why the power will increase? I can ask you what will happen and I give you the answer as the power it will increase, or what will decrease, the beta error will decrease. So always when the power increase, the beta, it means there is less beta error or type 2 error. So in the answers, you will find either beta, by increasing the sample size, the power of the study will increase, or by increasing the sample size, beta error or type 2 error. So in the answers, usually they give you type 1 error and they give you type 2 error. So whenever you're seeing increasing sample size, pick the type 2 error. It's not type 1, it's type 2 error. What else here? Okay, this is in terms of the sample, because you will be able to detect the difference if it truly exists. The effect size, the word itself, the effect, it's kind of confusing, but understand it in a way of a difference. So if there is a big effect or a big difference in the effect between the two. So if I'm like the question about, for example, glycine and inositol, something like that. If there is a big difference between these two, you will be able to differentiate between them. You will be able to detect the difference between these two. But if there is an overlap in their, chemistry or in their organic, compounds or whatever, if there is an overlap between them, it will be harder for you to detect this difference. So as you are increasing the effect size or the difference between two groups, you will be, as you're increasing this one, you will be able to detect the difference between these two, and you are increasing the power. So increasing the power means you are increasing your ability to detect the difference if it exists. So you're going to be able to detect that difference if you're increasing the effect size. And what else here in the effect size? Yeah, another example, I like to understand the effect size. If I told you black and white, if I told you to differentiate between them, if I give you the black color and the white color, is it easy for you to detect the difference between black and white? Yes, right? Because
Yes.
the effect size, it's high here. The difference between black and white, it's very big, like it's very clear. But if I give you the very dark gray and black, and I told you, are you able, what is your ability to detect the difference between a very dark gray and black? It will be harder for you to detect the difference between the two, because the effect size or the difference size between these two colors, it's small, or there is an overlap between these two colors. So the take-home point, that as you're increasing the effect size, you're increasing the power of this study. And for each one, you can have multiple different weight questions. And then for the alpha significance, the example that we just said, like if I'm telling you 0.05, this is the alpha significant. If I set it at 0.05 versus I set it at 0.01. So as you are increasing the alpha significant level, you are increasing the power of the study, because it will be easier for you to detect the difference, or it will be easier for you to say that there is a statistically significant difference between the two groups, or a statistically significant association. The same example I will give, if your study shows a p-value of 0.03, if I set the alpha level at 0.01, and in the same study, I set the alpha level at 0.01, this is 0.5 and 0.1, here I will say that there is statistically significant association, because here I'm accepting up to 5% that this association was due to random error or was due to chance. While here I am more strict. So I'm not going to accept this value. I'm going to say this is not statistically significant association. So increasing the significant level of the alpha from 1 to 5, this increasing the power of the study, because here it's like kind of you are more flexible here to accept that association. And then the variability, this is the only one that if it increases, the power of the study will be decreasing. The variability, it means the variability between the outcome of the data that you have. For example, if the values are all over the place, this is a less powerful study than when they are close from each other. And this is related also to the confidence interval, when you're having a narrow confidence interval versus a wide confidence interval. So if the values are variable or like distributed all over the place, this is a less powerful study than when you have a study that the values are close from each other, or when you're having a narrower confidence interval. And that's why if I give you the boundaries of confidence interval to be like, if I said 0.3 and 0.5 versus 0.3 and 0.9. So which one is better? So this one is better because the difference between 0.3 and 0.5 is narrower than the difference here. Or if I said from 1 all the way to 24. So this is a very wide confidence interval. This is a less powerful, a very less powerful study. So the variability in the data, as it increases, this is the only one that is having a disproportional relationship with the power. So as you're increasing the variability of the data, you are decreasing the power of this study. Any question here?
So the alpha significance level means if we increasing 0.01 to 0.05, right?
Yes.
So it's okay.
From 0.01 to 0.05, you're increasing the power of the study.
Okay.
And always remember this value. Like if you're having 0.03, if you set the alpha at 0.1, you will not accept this one. You will say that there is no association. But if it is 0.05, you will say yes, there is an association. And which means increasing the
so it's a point. It's not 0.3, right? It's 0.03, right?
Yes, sorry, 0.03. Yeah, thank you. 0.03. Yeah. So 0.03 here, if they didn't mention what is the alpha, it means 0.05, which means it is statistically significant. If they tell you it is 0.01, then this is not a statistically significant association. Any other question here?
Thank you.
No, thank you.
Okay, and then we come to also simple the measures of the central tendency. All the questions that can come here is like very simple questions. I can ask you to calculate the mean. I can ask you to calculate the median, or I can ask you as a concept. So how to calculate the mean? If I give you different values, for example, 20, 21, 22, and I want the mean. So we'll add these together, and then you will divide them by 3. This is simple. And if I give you the median, it depends. Do I have even number of data, or do I have an odd number of data? So if I'm having an odd number of data, so first of all, in both of them, you have to organize them. So if I'm telling you 3 and then 1 and then 5 and then 10 and then 11, something like that. First, organize them. So do the 1, 3, 4, organizing from the lower to the upper limit. After you're organizing them, if it is odds number like 1, 2, 3, like 7 numbers, you will take the middle one, and this will be the median. But if it is, let's say, 1, 2, 3, 4, 4 numbers, which is an even number, you will take the 2 in the middle. After you organize them, just make sure you're organizing them in order. So you will take the 2, these, for example, this was 2 and 3, so you will take 2 plus 3, and you will divide it by 2, and this will be the median. And another way about the concept, so both of these, they are they get affected by the outlier. So if I'm measuring the means of this data, and then I have another value which was 57, when I do the mean, this outlier will affect the mean. Same thing with the median, the outlier can affect the median. The only one that does not affected by the outlier is the mode. So mode, it does not get affected by the outlier. Why? Because the mode, it is, what is the definition? Again, what is the definition of mode? It is the most frequent number, right? The most frequent. So it doesn't matter if I do have an outlier or no, I will just look for the number that was repeated. So if 2 was repeated 3 times and 3 was repeated 2 times, the mode, even if I do have an outlier, the mode will be still the same, which is 2 because it was repeated 3 times. So it is the most frequent, which is 2. So this is regarding to the mode. Another thing, always when you have central distribution, this is the mean of central distribution. So you have like a central distribution, which is this one. So the curve, it will be like, it's not skewed. So in the central distribution, mean, median, and mode will be in the middle. And usually when you're doing a study, when you report the data, you report the mean of the data, usually. We had a question like if you are reporting the they tell you like if I told you I did a study, okay, I did this study, and then I'm supposed to report the mean, right? Why? Because I have a central distribution. But if I told you I did a study, and in this study I didn't report the mean of the data, I reported the median of the data, and I ask you why I reported the median instead of reporting the mean, I did that because because I had a skewed distribution of data, skewed data. So in the skewed, you have usually, we know that this is 0, right? And you have always positive here and negative here, right? So if you have the curve skewed to the right, so look at the tail. What is the tail? So if the tail to this side, so this is positively skewed, positively skewed. If the curve to the left, this is negatively skewed, negatively skewed. So this is why I'm reporting the median. Why? Because in the positively skewed, the mean will be skewed to the right, and it will be the largest number. So here you have 0, 1, 2, 3, and here -1, -2, -3. So the largest one here, it will be the mean, and then here it will be the median, and here it will be the mode. And same thing here, the mean, it will be here, the lowest or the largest negative number here. So the mean here will be the lowest value, and then in the middle, it will be the median, and then the mode. So both in skewed data, the median is the one that represents the median of the data. It is in the middle. It's not skewed like the mean. Here the mean will be the largest, here the mean will be the lowest. That's why if you are having a skewed data, whether it is to the right or to the left, you will report the median instead of reporting the mean. So the answer will be here. Why did I report the median? Because I have skewed data or skewed distribution. Okay, and then we have, okay, let's talk about the study design, and then remind me to talk about the bias. So we have the study design. So in the study design, what do we have? As we talked before, we have case control, which we just talked about, right? Case control. We have cohort. We talked about both types of cohort, which is prospective and retrospective. And then we talked about cross-sectional. And you have also case report, and you have case series, and then you have a case series, cross-sectional, and you have clinical trials. So all of these up to here, these are observational. This one is experimental. Okay. In this observational, because you don't have an active role, you're not like assigned, you're not doing an assignment. As I mentioned, like you're not coming to patients and tell them you will smoke, okay, and you give him the cigarettes, and you will not smoke. It's not like that. You just ask them. You will just say, are you smoker and or are you not smoker? So if he's a smoker, you will put him in a group, and non-smokers, you will put them in in another group. And you will just observe. You're not doing, like you're not assigning any treatment here. You just observe and look for the outcome of your interest. In the case control, we said, same thing, you have the disease status. So you will divide people into cases and control. And then in the cases group, sometimes they ask you like the question, how do you assign the control? What is the definition of control? So control definition, it is those without the disease, regardless to the exposure, because the exposure is the thing that you are looking for in case control study. So if you have any answer that shows that the control group, it will be those who are exposed or those who are not exposed, anything, you will just exclude it from the answers, because the exposure is the thing that you are looking for. So an example, like if you're having leukemia cases, what is from an outpatient? So what are the control group will be? The control, it will be leukemia cases from that outpatient, non-leukemia, like healthy people from that outpatient, regardless to their exposure, because the exposure, then you want to determine it. For the cross-sectional, we said you determine the exposure and the outcome at the same time. So you will just take your sample, and at that moment, for example, you will do blood test or genetic test, and then you will check their blood pressure at the same moment to make an association between any genetic component or blood component and the blood pressure or whatever you are looking for. So that's why we call it prevalence or snapshot. For the
Dr. Huda, regardless of exposure means they could be exposed or not exposed, but we don't know, right?
Exactly. Yes, we don't know their status of the exposure. We know their status of the disease, that this has the disease and this doesn't have the disease. Regardless of the exposure, this is the one that we are gonna ask or gonna look for in the medical record, and then we will see. Maybe they were exposed, maybe they were not exposed. So we don't know.
So Dr. Huda, for the cross-section, you said like you're taking the blood sample and checking the BP at the same time. So it is that at certain point where you are doing it at the present, that is the called snapshot, right? Like you're taking a picture.
Yes.
Okay.
Yes. I will take the sample at that point, and at that point, simultaneously, you are checking the exposure and the outcome. So you will do blood sample, genetic testing, whatever it is, and you will check their blood pressure, or you will ask which one is having hypertension or diabetes, and you will make the correlation at that moment.
Okay.
That's
so
why
when you compare this one with the case control, sometimes it's very confusing, right?
yeah, it's confusing, but if you know, like you will find the key. Did you check both at the same time, or you determine the status of the disease and then you were looking for the exposure, for the past exposure? So you will ask them, because for spina bifida, like right now you have this, you ask mom, do you have a kid with spina bifida? She will say yes. The other mom will tell you no. And then you will go back in the past. You will go to the past. Were you exposed? Did you take this medication? Were you exposed to this, chemical? So you're asking something in the past. So here the exposure was before the presence of the disease. But in cohort, at that moment, you might distribute survey. You will ask, do you have right now diabetes? Do you have, hypertension? And at that moment, you will check the blood pressure or check the genetic and make a correlation between the exposure and the blood pressure. And in this case, that's why we call it prevalence. Here we're looking for the prevalence. In case control, you're looking for the exposure status. In cohort, you're looking for the incidence of the outcome.
Thank you so much. Thank you.
Welcome. And then you have these two, the case report and the case series. All these three, we said we call them observational. It's observational and it's also analytical. So you are analyzing the data, okay? But here in case control and in case report, you're just having a case that you are having in the hospital or cases whom others like, report, and you're just describing. We call it descriptive. So it is observation, it is descriptive studies. So you're just describing that this patient come, he has these symptoms, his physical exam was like that, he was on this medication, we give him this medication. So you're just describing, and that's why we call it a descriptive studies. The case control, it's the case report, it is one case series, it is multiple cases. And the clinical trial, this is not an observational study. This is, you will come, it's not an observational. You will come, okay, and you have a new medication, and you have versus a standard or placebo, standard medication, or simply the placebo medication. And then you will take like a sample. You have this is your sample, okay, and you want to see the effectiveness of this medication and this medication on the outcome of interest. So why in clinical trial we don't call it an observational? Because here you're having an active role here. You are gonna assign the exposure. It's not you're not gonna go ask them, are you taking this medication? If he said yes, you will put him in a group. Or are you smoker? Are you alcoholic? No. You will randomly, the other thing that is important in clinical trials, it has to be random, and it has to be double blinded mostly. Like this is the best design, double blinded. And in each one you can get a question, or even regardless to the questions, as I told you, like for your like clinical knowledge. So random, I can tell you, like when I assign the people, I just put their names or their numbers on the computer, and I let the computer randomly assign like 10 of them in the new treatment, and 10 of them in the standard treatment, or the in the placebo. So why am I doing this, randomization? This randomization, it is good because it will minimize the effect of the confounders, both the known and the unknown confounders. This is the purpose of the randomization. And also when you are doing randomization, you are minimizing to some extent the sometimes of the selection bias. Okay, so you're minimizing selection bias, and also you're minimizing the confounders. So this is when you do randomization. So it's not like I'm not taking the treatment and give it to this group. I don't know which group take which. This is also important, because if I know, maybe I will pick the patients of interest. I will say, okay, I'm going to give this medication to this group and this medication to this group, and this will put me in so many like different bias that we're going to discuss later. So randomization is very important in the clinical trials. And the other thing, double blinding, what does it mean? It means you are blinding the subjects, and also you are blinding yourself as an investigator or as a physician. You will not know. So when I give you the medication, you will not know. So when I make the medication, like all the medications and the placebo, they will have the same shape, the same color, the same cap, everything will be the same. So all of you will take the same medication in terms of how it looks like. So no one know. You don't know if I give you the blood pressure medication or if I give you the placebo. The similar thing with the other groups. So the control and the cases, both of them will not know what they took. Because why are we blinding the subjects? Because we don't want to have a placebo effect. We don't want. We want to avoid the placebo effect, because maybe if you know that I give you the Panadol, your headache will be improved. But if you know that I gave you a placebo, you will say my headache didn't improve. So we want to avoid this one. And we are blinding ourselves as investigators, or the physicians are blinded to the assignment. Why? Because we want to avoid having observer bias. What is observer bias, and what is the best example of it? Maybe if I know, like observer bias happens usually when my own belief affects the results. When I report the results, my own belief will affect the results, or my own knowledge, or the stigma that I have from my society or my community. So if I know that African American people, if they took oral contraceptive pills, they are more liable to, or not oral contraceptive. If I know that African American women, they have higher risk of breast cancer. I'm just saying a random example, which is not true. I'm just saying, like, if my knowledge know that African American women, they have high risk of breast cancer. Okay, And then I did my study, and then I assigned some women, African American women. I gave them oral contraceptive, and I gave Caucasians oral contraception. And I want to know, and I calculated which one have the breast cancer over 10 years or whatever. When I report the data, I might report overestimate the presence of the breast cancer among the African American women more than the Caucasian. Not because they do have higher risk, but because of the observer bias. Because of the observer bias. Because I know that I gave the oral contraceptive to these. African American, or I know because I know that these women who take the oral contraceptive was of African American race. So if I know the race of the patient, or I know the assignment of the medication, maybe this will affect my clinical judgment, and I will over-report the presence of the outcome, and and also I will overestimate, or what we say, overestimation of the result. It's not because that truly happens. It could be because it truly happens, but it's mainly due to the observer bias. That's why in clinical trials, always we try to do randomization and also double blinding. And sometimes you might have a very long question, and all you need from that question, just the first line, just the first line. In the first line, they will tell you like, this is a single blinded study. So just by saying that, you will pick the answer that shows observer bias. This is an observer bias. Why an observer bias? Because there is it was a single blinded. If you didn't blind the physicians, or another thing, which is the placebo effect. The placebo effect, if you didn't blind the study group.
So observer bias is always from the researcher, right?
Yes, observer from the investigator or the researcher.
Okay. And this clinical trial we do usually for vaccines and drugs, right?
For what?
So this clinical trial we usually do for vaccines and drugs, right?
Usually, yes, yeah. For the, you have like a new medication, and you assign it versus you will have cases and control. So for these cases, you will give the new medication. For the control, you will give the placebo for the control. And over the years or over the months or whatever, you will look for the, you will see the outcome. What was the outcome? Was it effective? Was it harmful? You will see the, like, you will also from the beginning, you will set like a primary endpoint that you are looking for. What is your primary endpoint? Are you looking to improve the hemoglobin A1C, or what is your primary endpoint from using this new medication? So you will set a goal, the primary endpoint, and then you will measure this outcome or this primary measure endpoint to say in the end, yes, this treatment was effective, or this vaccine was effective in reducing the incidence, or this treatment was effective in prolonging the survival of the patients, all these things. So usually you have, and as we said, there is, and you will, like I can give you like study A and I can give you study B. And I tell you in study A, the investigator did he asked the people, or he know the status of the people while in of the exposure, while in study B he assigned. Here he pertain, here he assigned. So what is study A? Study A is observational, because in study A you didn't do any assignment. You just ask, or you just know the status of the patient, you pertain the status of the exposure. While in study B it is experimental study, which is the clinical trial. Okay, so this is in terms of the types of the studies. Another thing which we have discussed a lot, like so many times in the Skype group, about the independent versus the variables. This is also very important, especially for step 3 and step 2. So the variables. Whenever you have, as we said, like always look for the answers before you, when you see Biostat, like just look for the answers to see if this is a Biostat question, and just skim through them. So if you're seeing this, logistic regression and linear regression or correlation chi-square, especially in these questions or in any question, when you read the question, even if it is long, you will focus more. You will focus. You're not gonna read it just very quickly before you read the answers, and then when you see the answers, you will have to spend another time to go back again to the question and check. No, when you know what the question is talking about, when you read the question, you will know that oh, this means this is the exposure, this is the outcome. So this is quantitative, this is qualitative. Oh, this is the exposure, which means they started with the exposure. This is case control. This is so when you are reading the question, you will save yourself a lot of time. You will not need to go back to the question and spend another 1 minute to read it again. So for the variables, always to approach these questions or which type of study analysis you're gonna use. First of all, ask yourself, which one is the exposure? What is the exposure? And what is the outcome? The other name for the exposure, we call it independent. Independent. The other name for the outcome, we call it dependent. So when we are kids, or our kids, they are dependent. Why they are dependent? They are depending on us, right? They're depending on us. While when you grow up or after 18 or whatever, you become independent. So you don't need, you're not depending on your parents in supporting you or whatever. So the outcome, we call it the dependent variable. Why? Because it depends on the exposure for its presence. Usually, like outcome, like lung cancer, for its presence, it depends on the presence of the smoking. While the smoking, it's there, like it doesn't need the, it doesn't need the outcome for its presence. So the exposure is there, it's already there. You are either smoker or non-smoker. This is independent. And then for its presence to happen, the cancer needs to happen or depends on the presence of the exposure for its presence. So that's why always we call the outcome as the dependent and the exposure as the independent. So we have variables. We said we have exposure. This is the first question you're going to ask yourself. And then what is the outcome? This is called independent, and this is called dependent. Okay, number 2, ask here the same question you're going to ask here. Do I have category or do I have number? Values. Same thing here. Do I have category or do I have numbers or values? What is the other name for this? We call it categorical data or quality. When we say quality is better than quantity, it's quality. It's like yes, no, woman, men, female, male. You have the disease, you don't have the disease. So it is quality. So quality and categorical, they are the same. Numbers, we call it continuous variable or we call it quantity. So they all have n, quantity, continuous variable or number. So quantity, same thing here, quality and quantity. So you will ask yourself when you see these questions about chi-square, correlation, all these, you will ask which one is the exposure, which one is the outcome, because they might tell you so many things in the question. They will tell you hemoglobin, A1C, obesity, BMI, blah, 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 so many things. So you need to know which one is the independent variable and which one is the dependent variable. When you read the question, I want to know an association between two things. Which one is the exposure? Which one is the outcome? So what is the question is asking me about? And then after that, you will check this exposure. Is it only one or more than one? Same thing with the outcome. Is it only one or more than one? Because I'm saying this, which is kind of not related to this thing, but in case control, for example, in case control, always, not in case control, in cohort. In cohort, always we are looking only for one risk factor, and you can have one or more outcome. We have a question like that. So usually you're checking the smoking only. So you have to have only one risk factor in cohort study. because you can't have multiple. Like if you're having other factors, you have to adjust them because they can play as a confounders. If they are present in your equation, they might confound the effect of smoking on the lung cancer. So the outcome that you will have, you will not know, is this cancer happened because of the smoking or because also of other factors that played as a confounder. So always we need only one risk factor, but for the outcome, you can have multiple outcomes. It can be only lung cancer, it can be also oral cancer. So it can be multiple like outcome, but the risk factor, it has to be one. And then here for the variables, we said ask yourself, is it only one exposure variable or more than one? Same thing here. And then you will see, is it categorical or quantitative? And then you have to know which one is which. So simply, you have this table that we are very familiar with. We have this table, right, which is which shows you here. So here we have the dependent or the outcome variable, and here you're having the independent variable. So the dependent variable, we say like, is it categorical or is it categorical or is it linear? So here, categorical, and here continuous or quantity. And for the independent variable, which is the exposure, same thing. Is it category or is it quantity? Okay, so here let's focus on this one and on this one. Okay, so this one, if you're having a categorical dependent variable and a categorical independent variable, which means, an example, I will give you an example here. If I tell you I have group 1 and group 2 and group 3. Group 1 have hemoglobin A1C between 5.5 to 6, group 2 from 6 to 7, group 3 from 7 to 8. So this is numbers, right? But I make them in categories. So you will not consider it as a continuous variable. You consider it as a categorical variable. So these are numbers. I categorize these numbers into three groups. And I told you I want to find the association between this hemoglobin A1C, okay, and the development of diabetes mellitus complication in diabetic patients. So I have diabetic patients, and I categorize the groups based on their hemoglobin A1C, and I want to see the association between this hemoglobin A1C and the development of the diabetic complication. And the development of diabetic complication, how did I measure it? Just as yes, no. Yes, I developed the complication. No, I didn't develop the complication. There is no number. So this is category of yes and no, and this is category of three groups. So category and category. So this always will be chi-square. Chi-square. So chi-square, whenever you see that one of these two, whether the dependent and or the independent numbers, you will exclude it from the answers right away, because it has to be quality and quality, or category and category. In this side here, where do we have quantity and quantity? You have to have quantity and quantity. So if you see the exposure or the outcome is number, you would exclude. This is the correlation. Correlation is always here. It never comes with categorical data. So for the correlation, in order to say that it is linear correlation or whatever, for the correlation, here has to be number values. For example, hemoglobin A1C, if it is 5, 6, 7, or whatever it is, and here C-reactive protein, let's say, in numbers. So it has to be numbers and numbers. Okay, this is or quantity and quantity, or continuous variable and continuous variable, both the exposure and the outcome. So this is here, number and number. And then you will have the here the categorical and the quantity. There are two of these who it doesn't matter that what is the independent variable is. It doesn't matter if it is quantity or quality. These are the regression. So in regression, you don't care about the exposure. You don't care about the independent variable. It could be the independent variable. It could be categorical variable, or it could be quantitative variable. What you care about, so you will find you will find, for example, the logistic. If we started with the logistic, because we have the regression, we have logistic regression, right? Logistic, and we do have linear, right? Linear. So in these two, you care only about what is the dependent variable, what is the outcome. So in the logistic variable, which is here, it doesn't matter what is the exposure, but it matters that the outcome, it is category. So logistic, you will find it here, and you will find it here. Logistic. So logistic, you will find it as a categorical independent variable or as a quantitative independent variable. But the outcome, it has to be categorical. And the outcome, they call it dichotomous. If I'm not saying it wrong, dichotomous, which means the outcome, it will be, did you develop the disease, yes or no, which is dichotomous. So presence of diabetes or non-presence of diabetes. So it will be dichotomous, which means yes, yes, no for the development of the disease. So we call it dichotomous dependent variable. So it has to be logistic. For the linear, and the way we said you memorize this, how are you going to memorize that the dependent logistic variable, it has to be categorical. If you see, and this is from the our group, like this is categorical G, it will be with the logistic. So logistic, the outcome has to be categorical. And then for the dependent variable, you have the outcome. It has to be like the linear, it has to be continuous. So linear, you will find it both in both sides of the table. So the independent variable, it could be quality or it could be quantity. But for the outcome, the dependent variable, it has to be a number. And again, how are you gonna memorize it? Linear, it has in it, and it has to be quantity. So quantity and linear. That's how you memorize it. And that's it. So now you know the concept, and you might memorize this table and everything, but then you have to do more questions in order to apply this knowledge to the questions. So when you do the question, just train yourself quickly how to know which one is the exposure, which one is the independent, which one is the dependent, and are you talking about categories of data, or are you talking about numbers? And then we still have something here. Usually in the linear, the independent variable, it could be only one. So I can tell you, I want to know the association between smoking and let's say the smoking. I want something related to number. Let's say LDL, okay, or BMI and LDL. So if I'm saying, so I can give it as smoking, are you smoker or non-smoker, or I can tell you BMI, which is number, for example. It doesn't matter what is here. But what matters here, the number, the value of the LDL. I'm not saying if you're having high LDL or low D. If I say that, it will be categorical. So as a number, this will be linear, right? But usually in this linear, this independent or exposure, it could be one or it could be more than one. But when it is more than one, usually in the question, they will tell you, I want to do the association between the smoking and the LDL, for example. And I will tell you that there are other factors such as the BMI, the alcohol status, if you are alcoholic or not. So I will give you other variables. And in the question, they will tell you that they adjusted these variables. Why are we adjusting these variables? Because we don't want them to play as a compounder. We want to see the true association between two factors. So always when you want to do a true association between two things, the exposure and the outcome, if there are other factors that you think might play with this association, you have to adjust them between the groups. You have to adjust them between the cases and the control group, like the age. That's why we do adjustment for the age. So the more you adjust, the more you are eliminating the confounding effect. So for example, the age, sometimes the socioeconomic status, sometimes even the comorbidity. Like if I want to know the association between for example, obesity and heart failure, for example, or the mortality. So I want to know, did the patient, this association is true or maybe these patients who are having heart disease, they might also, some of them, they might be having also kidney disease. So you want also to adjust for the comorbidities to know that this association you have is a true association. It was not due to a confounding effect by these factors. So usually in the linear regression, you will have an association between two, and if you have multiple risk factors or multiple independent variables, they will tell you that we want the association between this, and we adjusted the other factors. And we will be left with two more things, which is the ANOVA and the t-test in this table. So same table, you will we are left with the ANOVA and the t-test. So ANOVA and t-test, they will be here. ANOVA and t-test. So in the ANOVA and in the t-test, the outcome has to be a continuous variable, or what we call quantity. And here it has to be quality. So the independent variable has to be quality, and the dependent variable, it has to be quantity. And it's not any type of quantity. It's not any type of quantity. It has to be the mean of the measures. The mean. So in the question, look for the word mean or for the word the average. So whenever you see these two, right away you will eliminate everything else. You will just focus on the ANOVA and the t-test. So if you are, if I'm telling you I have group A, okay, group A with mild disease, and group B with moderate disease, or sometimes it doesn't have to be about disease. Like I can tell you, I want to see how having a supervision, like for first year resident, the association between having a supervision from chief residents over the first year resident, okay, the first year resident. So it doesn't have always to be like in the question, doesn't have to be like related to diseases. I can give you something like that. So I'm dividing the groups into one group who has the supervision, another group who doesn't have the supervision, and then I want to see like what is like the satisfaction, or what is the outcome of their performance, or of the safety, you know, of the patient safety. I want to know the association between having a supervision on the safety of the patient. So you can have some questions like that, which is not related to disease and non-disease status. So going back, so if I told you like I have group A, group B, and also group C, and group, if I told you just two groups, group A have mild disease, and group 2, they have moderate disease or severe disease, and the outcome, I told you that I'm comparing the pain score, mean, the average of the main score mean, or sometimes I found the question, they didn't mention the word mean and they didn't mention the word average, but by elimination, none of the answers, like it's not chi-square, it's not correlation, so you will be left only with ANOVA and t-test. So even in that case, you will assume that you are talking about the mean, but usually they tell you in the question if it is the mean, or if it is an average. So if I'm comparing two groups and I want to know the mean of their pain score, this will be t-test. So t-test, it is two groups. While the other one, which is if I'm comparing three groups, so more than not equal, three groups, three groups or more, this will be ANOVA. So comparing the average of these three groups or more, this will be, or more than two groups, this will be ANOVA. What else we have here? I think that's pretty much it in terms of these questions. The means of the two groups. Yeah, there is another one, which is the one that we didn't cover. We have also pair t-test. In pair t-test, it's we have two types of it. One type, let me delete this. So In pair t-test, you will have two types. The main thing that we always know is that you don't have a comparison group. You have one group. So you will take this group. You will measure their blood pressure, for example. You will give them the treatment. You will ask them take the treatment for 3 months, for example. And then you will measure their blood pressure after the intervention. So before the intervention, and you will wait for a period of time, and then you're gonna measure. So this one group, it doesn't have another group for comparison. All it does, like, it serves as its own control. So it serves as its own control. This is the control, so this is considered as the control, and this is considered as the cases. So this group serves as its own control, which means before you have the intervention, you check their blood pressure, and then after you check their blood pressure and you compare, and you will say, yes, this treatment was effective or not. This is, we call it the pair t-test. The other way you call the pair t-test, you can also have two groups. You can have two groups, but they have to tell you in the question that you the observations, for example, the observations in group one was matched with group two. So if you do matching between the two groups, this is also another way of saying pair t-test, and sometimes they call it dependent t-test, dependent variable t-test, because the opposite of the dependent one is the one that we talked about, when you compare the two means of two groups only. We said this is t-test, right? T-test. Another name for it, you can find it, which is independent variable t-test, because when you are comparing the two groups, they will not tell you in the question that they did matching between the two groups. So they will not say we did or we didn't do. So just by not saying, you will assume that there was no matching. So again, we have t-test. T-test, usually you can just simply say sample two test, or independent, not variable. Did I write variable? Sorry, independent sample t-test. And here it will be a dependent sample t-test or pair t-test. So this is the difference between the two. And we talked about the chi-square. Chi-square, we said it is two categorical, the independent and the dependent. It has to be, both of them has to be categorical, right? So categorical, the dependent and the independent. So if you have categorical, the dependent and the independent, you have two types. You have either chi-square or you have the Fisher. The only difference between the two, in this one, they will tell you the sample was less than 20. So I will give you a sample that of two groups, one of them is 9 and the other one, for example, is 20. And out of these 9, we have 3 who developed the outcome, and out of these 2, we have 5 who developed the outcome. So because the sample size is less than 20, this is Fisher. If it is large sample size, this is chi-square, and both of them are the same thing. It's only different from the in terms of the sample size. Any questions so far?
I think we are good.
No, we are good, I think. Thank you.
Dr. Huda, can you just say something one more time about the chi-square, please?
Chi-square, in chi-square, like I will give you the independent, which is the exposure. The independent, it has to be category or qualitative, which is the same as qualitative.
Okay.
The dependent also has to be category or qualitative. It can't be numbers in chi-square quality. So for example, I can give you that I want to find the association between an exposure and outcome. I did a study and I have group 1, group 2, group 3. Group 1 has LDL who are having LDL less than 100. Group 2 who are having between 100 and 120. Group 3 is more than 120. So this is 3 categories. Although LDL is a number, but we can't consider it as a quantitative. We consider it as a qualitative data because I put these numbers into categories. I categorized it into group 1, 2, 3, or I categorized it into mild, moderate, severe, whatever it is. So I want to find the association between LDL here. LDL will serve as the independent and it is category, and the development of the MI. So do you have MI or you don't have MI? Or you don't have it? So this is category, 2 categories, which is people who developed MI and people who did not develop MI. So I am doing the association between a categorical data, categorical independent variables and categorical dependent variable. So this is chi-square. Chi-square. Sometimes I can tell you same thing, but I will tell you that the sample of in these people, it was 20 patients were here and 9 patients was here. So when you see the sample of the study in each group, it's not collectively. In each group, less than 20 here and less than 20 here, you will not use chi-square analysis. You will use Fisher. You will use the Fisher analysis. Okay, you will use Fisher analysis when you have just a simple data. And like yesterday, someone gave us a way to memorize a Fisher that you need to do like a lot of fishing to detect, you know, when you have a small sample size. When you have a small sample size, you will do a more, you know, fishing and digging to detect the outcome that you are looking for. So Fisher analysis, it's always with these small samples of the study. Chi-square if it is more than 20. Okay.
Please, can we give an example of the logistic regression when the dichotomous result is, we are looking for the dichotomous result?
Logistic regression, there are so many examples, but I told you, like in logistic, I can give you like the same example that I have 3 groups or 3 categories as the exposure. I can have 3 categories, or I can give you number like hemoglobin A1C, for example, as a numerical data. So it doesn't matter what is the exposure is. And then I want to see this association with the presence of the diabetes mellitus. For example, presence of diabetes mellitus or no presence of the diabetes mellitus. So this is in this case you will use the logistic regression. But I think we can have a more accurate example. You will find it in step 3. There is, I think, 2 questions in step 3, and I don't remember if there's in 2CK a question that explains that. If I find another like more detailed example, I will give you. But this is in general. We call it dichotomous categorical dependent variable. But the independent, it doesn't matter. Okay, so this is for the logistic regression. Okay, what else? Any question here? Screening. Okay, there are also one of the simple things that sometimes you like you don't want to miss in the exam. Usually when you are when we're talking about screening and its association with the survival. So if I tell you I have a new test, if I tell you that usually people who have lung cancer, they come usually to the physician at this point when they have the symptoms, right? When they have the symptoms, they will come and then they will die here. They will die here. So, and then I come to you, I told you I have a test, I have a new test. This test improved the survival because I tried this test and this test detected the disease here. The disease was detected here. And then I calculated the time from here to here. I know that here people, they live only 1 year after the diagnosis, but because of my test, My test improves survival because my patients, they lived for 2 years or 3 years. Actually, this is wrong. This is wrong information. Why it is wrong? Because your test, your new screening test, it did not improve the survival. All it does, it just detected the disease earlier. But if you're gonna, like the patient, this patient, he developed the disease at this point as well, but he came to you when he has the symptom. While this early screening test, all it does is just it detected the disease earlier. But both of them, when you calculate, both of them live the same amount of years, which is 2 years. So that's why we call it lead time bias. And we said always for the lead time bias, the keyword for it is in the question, you will find early detection. So whenever you see that there is a test that shows early detection and they tell you the investigator concluded that this test improved the survival, you will pick the lead time bias. This is a bias, it's not a true information. It's a biased information. The other way, if I told you that I have a new screening test, but this screening, it only detects this slowly or mildly progressive disease. For example, in prostate cancer, right? In prostate cancer, usually it has a slow progression, right? So I can detect the cases. So you will have like here, but some patients they have rapidly fatal progression. So when you have a new test, a new screening test, you will just detect those who have a slow progression of the disease, like those who are live longer. But for those who have rapid progression, who had the disease and then died, have the disease here and then died, have the disease and then died, you will just calculate those who are still alive and they have mild progression, but you did not calculate those who had a rapid progression of the disease. So whenever the keyword in the question you see that you are doing a test that has rapid versus slow progression of the disease, or we say the progression prognosis, or what else we said. Anything in this format, rapid versus slow progression of the disease. This is length time bias. So it is about length time bias. It's not lead time. So usually they confuse us between lead time and length time. So length time, it's related to the rapidity and severity of the disease or of the progression of the disease. What else here? Compounding, screening. Another very important thing that usually we get confused, although we understand its concept. When you're having these two curves, we know that always people who are here, these are in this line here. This is the disease population. And in this line here, we have the healthy population. So anything that will make you detect more disease, it will increase the sensitivity, because what is the definition of sensitivity? What is the definition of sensitivity? Sensitivity is a very simple thing, right? But what is the definition? I'm sure that if I ask you, all of you know it, but when you say it, maybe you're gonna say it in a different wrong wording, like unconsciously, although you're understanding it. So sensitivity and specificity, when you talk about it, you're talking about the test itself. You're talking about the test of itself. So if you do have disease population, what is the percentage that your test will be able to detect all these disease population? So what is the probability that this test will give you true positive rate, which is in the top, right, in the numerator? And it will give you the least amount of the false negative rate, because you don't want to test if you have 100 diseased people. You don't want your test to come here and detect only 50% and give you 50% false negative rate, telling you that no, you don't have the disease when you truly have it. So this is why always sensitivity, it is related to the true positive proportionally and disproportionately with the false negative. So you want to have the least false negative rate in order to increase your sensitivity. That's why always N is related with N. So sensitivity, it's always related to the false negative. You want to minimize this to increase this. And it's always related to the what we call the snout, right? Because you want to rule out the disease. So you want when this test tells you don't, if my test has 100% sensitivity, it means when I tell you that you don't have the disease, it means you don't have the disease. This is a true negative. So that's why we call it snout. We're ruling out. So you want a high sensitivity because we want you to detect more cases. And I want, when I tell you you don't have the disease, I don't want you to have a doubt. I want you to be sure 100% that you truly don't have the disease. Okay, when I have 100%, and I give you a negative result, it means you don't have the disease. When it comes to the specificity, same thing. Specificity, we're talking about the test itself. But in the healthy population. So if I'm having a 100% test with a 100%, what does it mean? It means what is the probability? This is the probability that this test will give you a negative result if you don't have the disease. If you are healthy, what is the probability of the test that it will tell you you truly don't have the disease? So what is the probability that if you don't have the disease, you will get a negative result? So these people, anyone who comes from here, if I do my test on him, is my test gonna tell him you don't have the disease, which is the true negative, or my test is gonna give him a false positive result? A false positive result. So if it gives him a false, like if it is 50% specificity, it means 50% will get a true negative result, and the remaining 50%, I will tell them that you don't have the, you do have the disease, when in reality they don't have it. So it will give you a positive result when you don't have it, and we want to avoid that. That's why always the specificity, it is related to the true negative, but it is disproportionately related with the false positive. So we want to minimize this as much as possible in order to have a higher specificity. And for memorization, P with P and N with N. So these are disproportionately related. And then the other thing, we call it spin, right? Spin. Why? Because you are ruling in the disease. So if I have a test with 100% specificity, it means when it comes negative, you don't have the disease. But if it comes positive, it means this positive, it is a true positive one, because my specificity is very accurate. So if I tell you you don't have it, it means you don't have it. And if I tell you that you do have it, it means this one, it's not a false positive. Because if I have it as 100%, if I tell you a positive result, the probability that this result, it is false positive, is 0, because this is 100. So it is 0. So if you get a positive result, it means you truly have the disease. That's why we use sensitivity for screening purposes, and we use specificity for confirmation purposes. This is to rule out the disease, because if you do have it, it will tell you that you have it. But if I tell you you don't have it, it means you truly don't have it. This is to rule out. Here we use it to rule in. So when you have a positive result, it is a truly positive result. It's not a false positive result. So here, as you see from the definition, we're talking what is the probability that the test itself will detect your disease if you do have it. This is sensitivity. And the test itself will be able to tell you that you don't have the disease when you are healthy. So it is about the test. But when you come to the positive predictive value and the negative predictive value, we're not talking about the test. This is, we call them post-test probability, after you are done with the test. So you already did the test that has this amount of this percentage of sensitivity or specificity. You're done with the test in the positive and negative predictive value. We're talking about the post-test probability. So if I did a test and this test tells me like I do have the disease, this test tells me that I have a positive result. Okay, I have a positive result. Okay, I want to know what is the probability that I truly have the disease. I do have the disease, so I have a positive result. I did ELISA, and the ELISA showed me that I have HIV. what is the probability that this test was truly positive? What is the probability that I truly have the disease? So this will be the positive predictive value. But if I did a test and this test was negative, and then I want to know what is the probability that I truly don't have the disease. I truly don't have the disease. So this is the negative predictive value. So this is post-test probability. I already have the test result, but I want to know, I want to believe it. Is it truly I do have it, or is it truly I don't have it? So these are the post-test probability about the positive predictive and negative predictive value. And that's why their definition is what is the probability of truly having the disease giving a positive test result. And this is what is the probability that you don't have the disease given a negative test result. And then when I tell you about moving the cutoff point, this question, we have a lot of questions about this. So just by imagining, if I give you, if you are here and I told you we're moving to here from B to A. So just by visualization, if you're moving to this direction, you will be able to detect more diseases, right? You will be able to detect more cases. So by detecting more cases, you will increase the true positive rate, right? So you are increasing the true positive because you will detect more cases which are truly existing. So you are increasing the true positive. And always these small curves, when it is here, this is everything is here is positive, everything is here is negative. So this is true positive, and this small one is false positive. And this is true negative, and this small one is false negative. So when you're moving from here to here, you are also decreasing the false negative. So the false negative will be decreased here. So by increasing the true positive and decreasing the false negative, you are increasing the sensitivity. So decreasing the cut, because as you're going to the right side, you are increasing the values here. So it's like here 0, for example, and 1, 2, 3, 4, and same thing here. So moving from right to left, you are increasing the values. So if I told you the opposite, if I'm decreasing the cutoff point from B to 1, here you are increasing the sensitivity, and by increasing the true positive, decreasing the false negative, and always sensitivity, we said the N, right? We said N. We said sensitivity. So just memorize one thing, either sensitivity or specificity. Understand it, absorb it, memorize it, and the opposite will apply to the other one. So for me, I'm memorizing the sensitivity. So always sensitivity, it's related to the negative predictive value and related to the false negative. So whenever you see the small curve decreasing, so by moving the curve from here to here, so this one will be decreased, and this one always has a disproportional relationship with this and this. So by decreasing this, it means like this, false negative, and here same thing. It's 1 divided by false negative. So by decreasing the false negative, you are increasing the sensitivity and increasing the negative predictive value. So whether I told you what will happen if you move from B to A, first of all, make sure that you are reading the letters right, and you are looking in the right direction. So don't read from A to B and then you look this way. No, make sure that you are reading the letters right and you are looking at the right direction that they are asking. So if I told you from B to A, it means I'm decreasing the cutoff. So by decreasing the cutoff, I will be decreasing the false negative, which means I will, so the question can be decreased, the false negative rate will be decreased, or the question could be about the sensitivity. So sensitivity will be increased, or the negative predictive value will be increased. The opposite of that, by decreasing the cutoff, you are increasing, actually, when you're moving like this, you will be increasing the false positive, and increasing the false positive will be decreasing the specificity and also decreasing the positive predictive value. Always B with B with B, N with N with N. Okay, we covered the most important things. Just one more thing, and then you can we can start. You can start to asking me questions. So here, the survival analysis. when they tell you, like, if I told you I did a study, okay, for cancer treatment. I have 2 medications, and I explained this a lot during the Skype session. So I have 2 medications. I have medication A and I have medication B. So medication, and I have I have 100 patients here and 100 patients here, and I tested them over a 2 years period. By the end of 2 years, 80% died here and 80% died here. And I told you my conclusion. Drug A better than drug B in treating or in improving the survival. Seriously, like how you have 80% here and 80% here, same amount in both groups who died, and you're saying the survival of patients in drug A is better than the survival of patients in drug B. So the idea here